CSF leak, and I think it would be more difficult because the canal is more narrow, but in actuality it's not that much different because the canal is shorter, and so your flap tends to be a little bit longer, just so it's long enough. But in general, I don't find much of a difference. I think the big difference would be that if it's still a child who's otitis prone, and that you have to take that decision making into the case, or whether you're going to do the case or not at all. You have to look at the contralateral ear more, and not to say you don't do that in adults, but I think you have to be more conscious of that in children.
So that brings me on to the important question that everybody always wants to know the answer to, is what age do we do tympanoplasties in children? So maybe we'll just go along the line. Maybe we'll start at the other end. Dan, do you want to start with what age would you say that it's okay to do a tympanoplasty? So they're going to be mitigating factors, aren't they, according to the
So your slides and your invitation to participate on this prompted me to do some homework. I was a little bit slower adopter than Dan and Michael. In 2015 is when I really committed to doing a lot of endoscopic chronic ear work. And so over the past 4 years, it's been a little over 430 tympanoplasties that have been totally endoscopic. And I don't know. I would argue. Struggling. Focus me again back on your question.
Yeah, no, the age really in terms of.
So I looked at the average age, and my range is from 4 for things like congenital cholesteatomas up to about 18, and 99% of my practice is pediatric now. But the average age range was between 8 and 9 years old.
Okay.
About roughly 60% of my patients adult. I make an endoscopic tympanoplasty for them also. My tympanoplasty and all of the ear surgery, especially for the middle ear pathologies, I generally use the endoscopic approach. It is same technique.
And what would be the
400 plastics, 2/3 of them in adults, and for me the difference is more the eustachian tube function, I know that the patient, the older patient, the adults, I know that the eustachian tube is not functioning. So, I can arrange different, techniques, or maybe more solving solutions than in children, and sometimes I hope that he's going to develop a better function of the eustachian tube. I've operated children from 2, small cholesteatomas, congenital cholesteatomas, but my age would be 5, 6. Sometimes I usually operate before 5 in cases that the patient has a lot of, chronic otitis, curative episodes, and sometimes, the parents call you if it's possible to own anything. I don't have good experience in that cases, In the end, I have another perforation, but sometimes the big perforation comes small, and you solve a little bit the problem of the patient.
Okay, thank you. Brandon, do you have an age cutoff for tympanoplasty?
I mean, in general, I try to avoid doing tympanoplasty until the age of probably around 6 years old. I don't have the specific data on what my tympanoplasty cases are, but certainly I consider someone a little younger if they have a very large conductive loss and the parent doesn't want to do a hearing aid, or if they're having issues with speech development and I can't get them a hearing aid. We have a large Medicaid population in Texas, and if you have unilateral hearing loss, we can't get a hearing aid for them. So in some of those cases, I'll go a little earlier, but I want to make sure that their other ears not pathologic. So.
The other ear is really important if that's possible, if they don't have bilateral perforations. And I think, particularly that scenario, trying to potentially get the hole smaller, but maybe not gone, which means that I often will tell them that I'm going to do a tympanoplasty if they're younger, if they have a large conductive loss, but we may put a tube back in soon after that, with the hopes of improving their conductive loss. I think for those younger children, I think it's really important to counsel the families that way.
Okay, good. All right.
My practice is about 2/3 adults and 1/3 pediatric, and I have a couple of pediatric otolaryngology colleagues, and they love to do the type 1 tympanoplasties. So they will typically operate usually around the age of 8 or 9, depending upon the contralateral ear, and then I have the benefit of seeing the patients that they are less interested in operating on. So typically patients that I see have very poor tubal function, concerns for keratin growth and things like that. But I, in general, like to counsel the family that unless there is a really good secondary reason why we need to operate, having a hole in the drum can be an okay thing for a short period of time, and around 8 or 9 is an okay time to do.
Okay.
One other thing I'll do is if it's more of a tympanoplasty for an adult drum, then I will, but they have a large conductive loss, then I'll put a cartilage graft in with a T-tube inside you in the cartilage graft. And it's, those tubes tend to last longer, especially if you know that if the kid's 9 or 10 years old and you know they're going to be a chronic care patient for, unless Boaz's trans-ear balloon works, they're going to be a lifelong ear patient essentially. So I put a T-tube through the cartilage graft, and that will stay in for quite a long time. Not always, but a lot of the time.
You tell me how you do that, Brandon, because I had a go at doing that once, and I was pretty happy that I managed to get this thing in the right place, because it's a bit of a bulky construction if you put the tube in the cartilage first, and it's pretty difficult to get it in second. My outcome was that it was great. The tube was in the cartilage, and then just above the cartilage was a massive perforation where it didn't heal. So,
what I'll do is I'll try to put the tube more either posterior or anterior inferiorly in the drum. The key thing you have to be careful of is that, or several key points, if you have a lot of residual drum left, then you have to find, if there's still drum over, you have to find a way to make a hole in the residual drum so the tube can come through. That's one problem. And then I typically have I harvest larger cartilage than I need to, mainly because I want the perichondrium. And then if I have extra perichondrium and say I have more perforation anterior to the cartilage, I have that perichondrium as kind of a safety net, and I always put it as a composite graft. And the way I make the hole in the cartilage graft is I use a 5 suction and just punch out a little hole like almost right next to each other, and then you can deliver the tube over a rosy needle or a straight needle through the hole. And then I don't know why they make tubes like a mile long. Like you'd think they'd come out halfway out there, So I always trim the T-tubes a little shorter, almost maybe like it's protruding maybe 2 or 3 millimeters out the graft, and then I cut the flanges a little bit too, just because they can fold over on themselves. And if you're having to put a tube through a cartilage graft that's already in, like someone's healed up, then the laser comes in very handy for that. You can use a diode laser and just make a hole in it, and then you can deliver the tube through that. So
if you're doing it in one stage, you put the tube into the graft before you put it in the ear.
Yes.
Yeah.
Trying to put it after the graft in is a fool's errand. So I put it on as one composite unit. So.
Okay, thank you. So we're getting towards the end of our time, and also, fortunately, towards the end of the questions that we had. And coming back to this topic of new perspectives, I'm interested in